As the world commemorates World AIDS Day today, let's take a look at South Africa's strides as well as challenges. I'm joined now by Dr. Seithati Molefi. She is the Deputy Chief of Party at Right to Care. A very good afternoon to you, Doctor, and thank you so much for your time. Before we focus specifically on HIV in South Africa, when we look at the numbers, in 2020, there were 1.5 million more people around the globe living with HIV and AIDS. Globally, is the fight against this virus being won, or is it still a challenge?
Good afternoon, Tammy, and your listeners, and thank you very much, actually, your viewers. Thank you very much for the opportunity. So, globally, we have not met the targets that we had set out to meet by the end of 2020. So, yes, we are still seeing new infections much higher than we have wanted to in order for us to attain the epidemic control that we had set out to attain. So we are not yet there, but there have been significant strides that have been made, and we are happy with some of the progress in a lot of the areas. For instance, when you look at the South African numbers and we look at how we've done on the 90-90, we know that as a country we have attained the first 90 as a country nationally, but we are finding that we are struggling quite a lot with the second 90, which is putting 90% of the people living with HIV on sustainable antiretroviral treatment. So we have not yet attained that target. And lastly, we have not yet attained the third target, which is ensuring that 90% of the people who are on antiretrovirals have a suppressed viral load. Now, it is also important to note that even within South Africa, there are some districts in the country that have actually attained the whole 90-90. So all those 90 targets in those districts have been attained. And now we are looking at the pockets of areas or populations that have not yet, in which we have not yet attained the targets. So in short, yeah, there's still a lot of work to do, but it is also quite encouraging that we have areas where we have actually managed to attain the target, so we can learn from there.
So when you talk about areas of South Africa that are still lagging behind and haven't yet achieved any of the 90% targets that have been set, which areas are you mentioning here, and are these areas provincially based?
Okay, so as I said, as a country, we've actually universally met the first 90. So all provinces have met the first 90 in South Africa. So where we actually have challenges would be in the second and the third 90. And maybe to answer you, it would be better to say the 4 districts that have attained, according to the latest data that was shared by the Department of Health, there are 4 districts that have attained the 390, so the targets for each of the 90s. And 3 of those districts are in KwaZulu-Natal, and 1 is in the Free State, in fact, which is Thabo Mfutsanyana. In KwaZulu-Natal, we've got Ugu, we've got Umkhanyakude, and Umzinyati.
And so, what are the challenges that are preventing us from meeting the targets in the rest of the other districts?
Okay, so I think that's why I was speaking about looking at the actual populations in which we are still struggling to meet the targets. What you will find is that even in the country and in the districts where we say we have had significant strides, there may be an overall population progress has been good and might have attained at a global level the 90 targets. But when you look at different populations, for instance, we know that in men, we are struggling to attain the targets. If we were to just look at the subpopulation of men, you will find that even in districts where we have reached the 90 targets, but amongst men, we have not attained it as well. So men and children are our biggest concern at this point in time. And then secondly, key populations or populations where it is generally difficult to access services. And obviously, these would be, the challenges are then linked to the various populations. So in order for us to address these, we must actually understand what is it about men that is causing the lag, and address issues and develop interventions that will speak to the issues that men face with access and us attaining the targets, as well as with children and other key populations or other hard-to-reach populations that we need to work with, because we do want to attain a global coverage of all populations.
Now, Doctor, when we look at groups that are particularly high as far as the numbers are concerned, young women seem to be of particular concern, and this is specifically between the ages of 15 to 24. What are the unique dynamics that this particular age group of women face that make their numbers so high?
Yes, so our biggest concern with adolescent girls and young women, particularly between the ages of 15 and 24, is that while incidence seems to have plateaued or stabilized amongst other population groups, and in some actually is starting to go down and is sustained at a lower levels, for this group, unfortunately, it's going up. And so this is the problem. So incidence being new infections, we are still seeing quite very high new infections amongst adolescent girls and young women. And to answer the question as to why we are facing these challenges, so we are seeing that amongst adolescent girls and young women, there are societal as well as psychosocial determinants of their vulnerabilities that then make them more vulnerable than other groups. So some of the determinants would be, for instance, the empowerment of women, and this is seen and is expressed more amongst the younger women, and them being disempowered means that they have limited opportunities or ability to negotiate safe sex. So you will find that amongst young women and adolescent girls, there is a high-risk behavior because of this, and you will find that they then struggle to negotiate condom use, for an example, or other measures of prevention that are in place. Secondly, there is we have seen issues that relate to early sexual debut amongst certain populations in the adolescent girls and the young women. These affect also the higher incidences or higher rate of infections. Other issues include intergenerational as well as transactional sex. So all of these are key determinants to the higher vulnerabilities that young women face. And of course, the psychosocial issues, looking at access to services, and also looking to access to, for instance, food security and so forth. So those are key drivers.
Dr. Molefi, let's talk a bit about the treatment now. Talk us through how, over the decades, the treatment for HIV and AIDS has actually changed and what the current treatment is.
Okay. So I think, if I can take you through the generations, it's been quite a long journey. So I think people would remember there was a time when people talked about treatment for HIV, antiretroviral treatment, they would talk about a few drugs, very few and limited drugs, and even the combinations. There was a time when people were even on monotherapy, meaning that people would be taking just one drug to treat HIV, and also there came a time when it was dual therapy, so there would be two drugs that were used. With time, and evidence showed that the most powerful tool in terms of treatment would be having highly active antiretroviral therapy, and this the mainstay of this is having triple therapy, at least 3 drugs of different classes, which would then attack the virus from different angles. And these combinations proved to be quite a game changer in the development of treatment. And with time, even the drugs themselves, the individual drugs themselves, have improved greatly. We know about the side effects that were quite topical and during the initial stages of the treatment campaigns. And what we then found is that with time, there was improved research and key developments in science and in pharmacology and pharmaceuticals that have led to better drugs being available, and these drugs having a better side effect profile, as well as being better at suppressing the viral loads, which is what we want to get to really when we give people antiretroviral therapy. So currently we have, yes.
No, please go ahead.
Yes, so what currently the newest drug that has been introduced to our regimen in South Africa is dolutegravir, which is now a drug that is universally available for those who qualify. And this is the drug that is quite robust in its action against HIV, quick to suppress the viral load and sustain that suppression. Secondly, has a much better side effect profile. So fewer people are reporting side effects, and especially those side effects that are quite severe and that will necessitate change in treatment or considerations for other therapies. So the dolutegravir has been the newest drug that has been added.
Now, Dr. Molefi, I'm sure you'll agree with me that the holy grail as far as health and treatment of viruses, etc., is the development of a vaccine. We still don't have a vaccine for HIV and AIDS. Why?
Okay. Can I start by saying, for me, the holy grail is prevention. And vaccines are part of that prevention arsenal. So in terms of an HIV vaccine, you know, work has been ongoing for various years on it. And as you would know, vaccines and any other therapies go through various stages of testing. And we've got clinical trials that are currently underway. And the current trials are at phase 3. So this gives us a timeline of maybe 3 years or more, so 3 years or more, should they be successful in those trials. So yes, it has been slower than, I know that currently people are comparing all vaccine development to the COVID vaccine. But I think when we look at these pandemics and how they've developed over the years, and the emergency or exigency of coming up with a solution, you would really understand that in terms of the COVID response, it was a massive global pandemic that developed quite quickly and rapidly, and its effects, even though the numbers, when you look at them, people will compare and say, but if you compare this with how many malaria deaths, how many TB deaths, how many HIV deaths we've had, these numbers are quite high, but we still had more deaths in other areas. But when you look at the time within which all these deaths had happened, really the response was quite different, robust. And it was multi-sectorial for COVID to a high degree. And also the type of virus that we're dealing with obviously is quite different. So the science in the development of the vaccines itself is a big stumbling block in terms of HIV. But I think also we are learning from COVID some of the things that we could do differently in the whole health system to fast track our responses and to bring more people on board at the same time for us to speak more or less with one voice. So COVID is really a good learning curve, and some of these achievements that we're getting out of COVID will definitely be used in the health space in general. But I do want to say that it is not because the fact that we don't have an HIV vaccine is not because there's no work being done or that work has stopped. It is continuing. There is hope. As I've said, the horizon is looking quite fair.
You mentioned there COVID-19, but how has this pandemic actually affected the fight against HIV and AIDS?
So you can imagine, as you can imagine, the initial response to COVID, population-wide, was that of shock and panic. We did not know really what we were dealing with at the initial stages. So when people got to learn about COVID and how some of the prevention measures that were in place, including social distancing, wearing masks, and limiting your contact with people. So these really led to a panic. There were people who were unsure of whether they should still access services. People thought that, look, if I go to a healthcare facility, chances are I'll meet other people who are ill, and the people who need to seek help for COVID will be in those healthcare facilities. So people tended to avoid going to healthcare facilities, even though those who needed to, either to go and test for HIV or to go and get treatment or continue their treatment. But fortunately, a lot of work was done to counter that. Obviously, the information sharing and people being made aware that healthcare is an essential service. Facilities didn't close, clinics didn't close, hospitals didn't close. They were still accessible to patients who needed them for whatever reason. So once the message got out there, people started coming back to facilities. People started being more comfortable when they saw the infection and prevention control measures that were being put in place to protect people from acquiring COVID in the healthcare spaces. People then became more comfortable, came back to the health spaces. But there were other measures that were put in place, for instance, to say, how do we ensure that only people who need to be in these congregate spaces, be it healthcare facilities or other spaces, go there. So in healthcare, what was done is, escalating, or shall I say fast-tracking decanting. Decanting being a process whereby somebody who's already on treatment is stable, has no side effects, has no complaints or other, issues with their health, can then go and access their treatment outside the facility, outside the healthcare facility. So this included people collecting their medication at pickup points, be it in private pharmacies, in supermarkets, in local areas. You'll find that even in the rural areas, maybe some of the local authority spaces were being used for this. So this also allowed people to, number one, decongest facilities. You don't have too many people at facilities at the same time, and people don't need to get facilities, don't have to go to facilities.
Dr.
Secondly,
Molefi,
people could also determine how they pick up their medication, and safely so.
Dr. Molefi, we thank you so much for your time and all that in-depth information on HIV and AIDS as we continue to even learn more about the virus itself and how to make sure that, as you said, the Holy Grail is prevention and then secondary to that, then the vaccine. Thank you so much. That's Dr. Seithati Molefi. She is Deputy Chief of Party at Right to Care.